Good afternoon, everyone. Thank you so much for this opportunity to present our studies at Hepatitis B Care Continuum and associated factors in Rwanda, a population-based study from 2016 to 2003. My name is Damascene Makuza. I'm from School of Population and Public Health at University of British Columbia. This is the list of my co-authors. And this is an outline of my presentation. In Sub-Saharan Africa, by 2020, it was estimated that 81 million of individuals were living with chronic hepatitis B. Among them, less than 2% were diagnosed. And among them, 0.1% were linked to care. In Rwanda, by 2023, it was estimated that 190,000 of individuals were having chronic hepatitis B. Among this population, 74% were diagnosed. And then among those diagnosed, 7,000 who were eligible to treatment were treated. And among people living with HIV, 4.3% were having co-infection, HIV and hepatitis B. From 2016 until now, a lot has been done in terms of managing hepatitis B. They started with screening of individuals, targeted individuals, such as people living with HIV, female sex workers, survivor of 1994, genocide, 44 years, and so on, as well as prisoners. While from 2018, there was mass screening of individuals aged 15 years and above. Then cases of hepatitis B were identified in general populations. Then from 2020 up to now, there is integration of hepatitis B services. So screening of hepatitis B is being routinely done at health facilities. Since 2016, about 5 million of individuals screened, 140,000 of individuals positive, but we do not have information on how many people were linked to care. While among those treated, we do not have the figure of retention rate, as well as we do not have information of treatment success, mortality, or impact of HIV co-infection on both treatment success and the mortality. Our objective was to characterize the hepatitis B care cascade in Rwanda and assess factors associated with losses at each stage of care cascade. We use the discrete health information system tool, which is a data set containing information of individuals who have been screened for hepatitis B from enrollment until evaluation of treatment success for those who were tested positive for hepatitis B. And these contain 5 million individuals having information on different variables like social demographic, socioeconomic, comorbidities, and complication death. In analysis, for characterization of hepatitis B care cascade overall by different categories in Rwanda, we defined the 6 stages of care cascade for hepatitis B management, such as chronic hepatitis B prevalence, diagnosis, engagement with care, patient eligible for hepatitis B treatment, patient initiated the hepatitis treatment, and the ongoing treatment. And in statistical analysis, we compute the proportion of compression of care cascade at each stage. We summarized categorical variables using assorted relative frequencies, and we computed care cascade stage in general by different categories. To assess factors associated with losses at each stage of care cascade, we used a retrospective cohort study design, and we include in this study individuals who were screened for hepatitis B and having information available on DHS2. And each stage of care cascade hepatitis management were considered as outcome. While covariate include social demographic, socioeconomic characteristics, as well as comorbidities. And we use a multi-level logistic regression to assess factors associated with losses at each stage of care cascade. As a result, this is a flowchart showing how we selected individuals who were considered in the final analysis. And this final analysis, we considered 57 1,520 individuals. And among these individuals, most of them were between 35 to 54 years old, female individual, married and competent, using community-based health insurance, screened for hepatitis B from July 2018 to June 2023, and followed up at less than 30 minutes from their home to a facility. And then the majority of this population didn't have information on hepatitis B DNA at baseline. This is the hepatitis B care cascade in Rwanda, which shows that among those who were diagnosed, 37.9% were engaged in care. Among those engaged in care, 28.2% were eligible to treatment. Among those eligible to treatment, 79.5% initiated treatment, while 97.4% among those who initiated treatment were attending treatment for more than 1 year. By HIV category, we found out that the high proportion of individuals of HIV negative were engaged in the care among those who were diagnosed, as well as individuals who initiated treatment. We are having high proportions of individuals who initiated treatment compared to those who were HIV positive. While those HIV positive, 99.3%, meaning the high proportion compared to 96.8%, we are attended in care compared to those HIV negative. Comparing categories of age, we found out that individuals who were less than 35 years old were having a high proportion of individuals who were engaged in the care among those who were HBV positive, compared to other categories of age, while those over 55 years and over we're having a high proportion of individuals who were eligible to treatment, who initiated treatment, and also individuals who were retained on treatment. Going to factors associated with each stage of care cascade, we found out that individuals who were aged 35 to 54 years old were more likely to engage in care, initiate treatment, and they attended the hepatitis treatment, while they were less likely to be eligible to treatment, while individuals who are followed 30 minutes to 60 minutes from the home to health facility were less likely to engage in care and less likely to attend in hepatitis B treatment. Individuals who were HIV positive, those who were screened from July 2018 to June 2023, those who were HBV positive, and those who were male were more likely to engage in care. To summarize, there is a low engagement in care among diagnosed individuals among our study populations. Then treatment initiation and retention in care were outstanding. Compared to those under 35 years old, mean young, those individuals aged 35 to 54 years were more likely to engage in care, initiate treatment, and retain in care. And individuals living 30 minutes to 60 minutes from health facility were less likely to engage in care or continue treatment compared to those living closer. To conclude, in our study, there is encouraging outcome initiation, the high rate of retention for hepatitis B treatment, which emphasizes the importance of hepatitis B care cascade, especially in evaluating hepatitis B program in sub-Saharan Africa. Then there is engagement in hepatitis B care cascade, which was low, particularly among young individuals and those living further from health facilities. So there is a need to continue increasing awareness among the population, especially those young and those advanced age. Then there is need to provide education resources to ensure individuals have access to hepatitis B testing, treatment, and the follow-up area. By this, I would like to thank for conference organizer for allowing us to present our study result. I would like also to thank my supporters, including my member of my PhD thesis committee, for their support. I would like also to thank Rwanda Biomedical Center, Rwanda Ministry of Health for providing data. I would like also to thank patient and healthcare providers. Without them, I would not have these results to present, as well as UBC School of Population Public Health for the PhD scholarship. I would like also to acknowledge CANEPC for a PhD fellowship. I would like also to thank all my colleagues from University of British Columbia Center for Disease Control, and Rwanda Biomedical Center for all kind of support. All of you, thank you for your kind attention.